So time for the Q&A session. So remember, for those of you who have questions, there are question cards in the middle, and Amanda is over there waving one wildly. So if you have a question, please flag her down. There's also 2 mics here, and we have assistants with 3 mics if you don't want to get up and go to a microphone. So we already have some questions up here. Rich, maybe you can read one of those.
Sure. Hello, hello. You can turn on.
Your mic's on. Your lavalier.
Oh, okay. I'll do this one. The question is if delirium is associated with poor outcomes, how can we assume that it is causative? We cannot. That's a great insight and an important question. So right now we don't have definitive causative association there. We know that the poor outcomes are associated with delirium. We don't know that delirium is the cause of those poor outcomes. So important point. Are there studies by which we can conclude that preventing delirium impacts outcome? None in the ICU. So there was a wonderful study by Sharon Inouye with about 800 patients outside the ICU, all elderly, where they randomized patients to a preventive strategy or not, and showed a dramatic improvement in outcome with those patients. That has not been repeated in the ICU as far as I'm aware. So.
Yeah, you go ahead, Mike. I think your lavalier's on.
Am I on?
Yeah, you're on.
Okay, great. First question for me, is there a place for intravenous lidocaine for pain treatment in the ICU? And yes, depending on what you consider an ICU. I would consider a PACU in ICU, and for that patient who is complaining of pain on a 3 to 5 pain scale in the PACU, but who keeps falling asleep and whose CO2 is 50, and for whom I'm going to get grief, I will use IV lidocaine and actually use an infusion for a while. But bringing them into the ICU, we're probably maybe 5 to 10 years away from that, in the sense that we're going to need some more studies to showing it's safe. We have a fairly high incidence of patients in our practice because of the traumatic brain injury, fairly high incidence of seizures and things, so that no one's going to actually run it in the ICU. And I think it'd be problematic right now, so I couldn't recommend that. I'll let that go with, I'll pass to another one, and then I'll take my second one.
Okay, am I on? I don't sound like I'm on. Now I'm on. Do the PAD recommendations for patients who have a history of dementia prior to their ICU stay, where cognitive baseline, I assume mental status, is unknown? Specifically, our recommendations are, for the most part, not targeting a patient population, but I can imagine a patient like this in most ICUs. I work in a VA hospital. There's a high incidence of dementia in that patient population. We have generally an older group. And I think the great challenge is trying to figure out the source of agitation in somebody who's already demented at baseline. So here's where doing your pain assessments first, using a behavioral pain scale, because presumably we're talking about somebody who can't self-report their pain, becomes extremely important, and not assuming that they're agitated for reasons other than pain, but start with pain meds and then see what you're left with, and only give sedatives if they're severely agitated in spite of what you think is adequate analgesia. And I think for a patient like this, trying to standardize the environment, reorienting the patient, familiarizing the environment, having family members come in is also particularly important in a patient like this. And then I think the second part of this question, are assessments made on patients at certain times of the day or night? So actually in the PAD care bundle, we recommend that pain assessments be done every 1 to 2 hours, and I think sedation assessments every 4 hours, and the delirium assessment should be done Q shift. So there'll actually be specific recommendations for the frequency of each of those.
Okay. What's the incidence of self-extubation with light sedation protocols? Great question. This has not been reported in some of the studies. In the ones where it has been reported, there was either no statistically greater incidence of self-extubation in the light protocols. In the ABC study, there was a higher incidence of self-extubation, but there was no difference in re-intubation rates. So what that means is that more than half the time the patients were right, they were ready to come off the ventilator. And that's the case with a lot of the self-extubation data. But it's a good question, but not a significant increase in re-intubation rates with lighter sedation.
I've got one on the explain the link between delirium and death, 6 months, and then post-op cognitive dysfunction. Unfortunately, it said speculate if you like, and ask your two colleagues on my left and your right if they would speculate as well. Now, I've actually thought about this a long time. I was fortunate when I was in medical school 40 years ago to work with the person who first reported on this out of the UK. And I think from the guidelines, Dr. Ely's perspective, this whole thing with delirium is linked, as we've talked, with pain and agitation. And then studies, you know, Dr. Monk received the Robenstein lecture here several years ago for her looks at postoperative cognitive dysfunction and what it's correlated with. You saw the slide with age, severity of illness. And so it may not be a true association or cause and effect between delirium, but delirium develops in sicker patients. That would be the easiest way to look at it. But because I think everyone in this room is paranoid about developing cognitive dysfunction before they die, it is something that we have to take very, very seriously, and I think most of us do, and hence the reasons for my current research interest, because that's what makes me the most paranoid. But I think you can explain the link, whether it's cause and effect is a completely different issue that will have to be addressed. Comments, either?
No, I agree. I think, you know, Wes Ely's group has published some very provocative information just earlier this year in Critical Care Medicine, where they looked at MRIs and volumetric assessment of patients and showed that if you had delirium, you had a smaller brain mass. And unfortunately, they did not have baseline MRIs on any of those patients. But nonetheless, they showed some other analogous clinical situations where it's conceivable that even a few days of delirium may lead to atrophy. And clearly, that's an irreversible process. So whether it pushes you way along your brain atrophy and aging curve, I don't know for sure, but it's a bit of a provocative thought anyway. One question here. If I understand correctly, there's no one treatment or management shown to decrease delirium. Is that correct? Remember that within the construct of the grade methodology, we had 4 different groups asking questions that were PICO questions, right? So what's the population, what's the intervention, what's the control, and what's the outcome? And in order for the outcome to be there, it had to be designed, the study had to be designed for that. And there really have not been studies where the primary outcome was, let's see if we can prevent delirium. They were downstream secondary outcomes, things like that. So right off the bat, you're dealing with not strong data to answer that specific question. That being the case, within the recommendations from the guidelines, there's a little bit of an apparent conflict. And one study says, one question answer says, we recommend using non-benzodiazepines because they may prevent delirium. And the other one says, there is no role for pharmacologic prevention of delirium. A little bit different wording on the questions, a little bit different PICO construct. So there is relatively consistent information that suggests that dexmedetomidine relative to benzodiazepines is associated with a lower incidence of delirium. Is that preventive? Is that treatment? A little bit more complex. The study I know best is the SEDCOM study, and there about 60% of the patients in both arms of the study had delirium at baseline. Of those 60%, if you look at who of them had delirium during study drug, during blinded study drug, it was about 68% in the DEX group. It was 95% in the midazolam group. So if you had delirium at baseline, you had a much longer and higher incidence of it during drug if you were getting midazolam. In the 40% that did not have delirium at baseline, only a third of those patients in the DEX group developed delirium compared to 55% in the midazolam group. So if you didn't have it at baseline, you got it more frequently with midazolam. Now that's one study, and I think what we'll see over time as more studies are done, maybe structured specifically to look more at delirium and the various perturbations thereof, we'll get more information for that. So.
I just have two follow-up comments, because I think delirium's kind of the new kid on the block relative to pain and generic agitation. And I would agree with everything that these two gentlemen have said, but I just want to emphasize the fact that delirium is a descriptive term. You're describing what you're seeing. It doesn't speak to the likely multiple underlying etiologies of delirium. And I think until we have a better understanding of the neuropathophysiology of delirium in critically ill patients, it's going to be very difficult for us to know what the right answer is in terms of the best strategies for both preventing and treating delirium. And delirium may just be a symptom of a sick patient. It's, as Dr. Murray said, it's the cause and effect relationship between delirium and treatment is still very, very unclear. And I think this is an area of great research interest worldwide, and it's certainly something I think we've tried to highlight in the guidelines, is we just don't really know. And this concept of acute brain failure, just like critically ill patients get multi-organ system failure, they get heart failure, they get kidney failure, they get gut failure. Well, it should come as no surprise to anyone that patients also are likely to be developing brain failure. And the long-term consequences of that are, I think, still very much in question. And there's a lot of current research right now trying to answer that question. But the brain in this instance in the ICU is very much a big black box to us. I have a follow-up question on the subject of delirium. Forgive me if I'm not asking this question correctly, because I couldn't completely discern the handwriting, but I believe the question is, what is the role of neuroleptics, thank you, in the prevention or treatment of delirium? So there are typical and atypical antipsychotics. Actually, there's very little data on either type of antipsychotic for the treatment of delirium or agitation in critically ill patients. For those of you who work in the ICU, you may be shocked to know that haloperidol, for instance, which is one of the oldest drugs we have in the unit, has actually never systematically been studied for its safety and effectiveness in treating delirium and agitation in critically ill patients. Some of the atypical antipsychotics are just now beginning to get studied. There was a small study of quetiapine that barely met our criteria for including it in the guidelines that did show some benefit in terms of reducing the incidence and duration of delirium. But again, I think this is one area that's ripe for clinical research to answer some of these questions, because if you look at the PAD care bundle, we don't really have good, clear evidence for what the best pharmacologic strategies are. We can talk about sleep, we can talk about hearing aids and eyeglasses, we can talk about early mobility, we can talk about ways to get patients off the ventilator and maintaining light sedation, but at the end of the day, that's all kind of dancing around the problem. We really don't have a clear evidence-based way for pharmacologically managing delirium in critically ill patients. Yes, sir. Do you have a mic someone can give you, or you want to walk up?
In a recent review article by a psychiatry department, one of the psychiatric journal. They explain that all the mechanism of delirium is producing of free radical, oxygen-derived free radical and nitrogen-derived free radical. Still the same treatment, still haloperidol, but I was asking me the question, why not using some drugs that have some effect on free radical? Maybe melatonin is one of these medication, N-acetylcysteine is one of the medication. Is anyway the way we try to treat some patient in pre-op now, patient of high risk of delirium during surgery.
That's a very interesting question. I don't know that there is any data in the ICU patient population looking at that issue yet, but I think that kind of research needs to be done.
Another question I asked also, what about the use of very low dose of ketamine in this? Because if there is a shrinking of the brain, one of the mechanisms is probably a large amount of glutamate release, stimulation of an NMDA receptor and toxicity of an NMDA receptor. And maybe not a small dose of ketamine like memantine is used for Alzheimer's disease.
Gilbert, thank you for the question. I've got it up here. So let me just answer two questions with one. One was about the use of ketamine. And I'll tell you that in this ICU where I'm working now, the protocol pretty much is for a delirious patient, if it's a quiet sedation, a quiet delirium, they'll use dexmedetomidine. If the patient's very agitated and intubated, they'll quote, anesthetize the patient either with propofol or ketamine. Propofol if their pressure is good, ketamine if their pressure is bad. No ketamine if they've got raised intracranial pressure. Having said that, in the military, probably 4 years ago, there's a big push for ketamine for the reason you mentioned, the NMDA receptors in patients with traumatic brain injury. I can't cite you the study, but at least in the patient population that they looked at, it didn't have an effect on outcome. And so now, in none of these patients with traumatic brain injury are they getting a low-dose ketamine. We use it to sedate the patient, but not for the reason that you mentioned.
The reason I tell you that because I'm doing a lot of pain treatment and all, we have a lot of these old people now, this very senior citizen. Huh? I am almost a very senior citizen. And now I have pain everywhere. Okay, there are all those opioids, some of those opioids, and then I always want to have more opioids because I always pray. And you give to this patient a very tiny amount of ketamine perros, 2.5 milligram, is very tiny. You are surprised that the pain is improving, but also they look brighter, they look much more clever than before.
You may have something there. I agree.
Yeah.
Thank you.
Different characteristics of the quiet versus the agitated delirium. Since we're trying to get a handle on etiology and mechanisms, is there some sort of study that's looked at for those two types of patients?
Yeah, so there are a couple different ways that the motoric subtypes have been defined. The more recent approach has been to use a sedation score, like the RAS or the SAS or Ramsey, and say that if they're agitated most of the time, it's an agitated delirium. If they're sedated most of the time, it's a quiet delirium, and if they swing back and forth, it's mixed. I think a better approach is an older one. I think Trepatch or one of the other older delirium researchers published this, and they actually had specific symptoms, and you had to have 3 of the 13 or 15 that were listed among the agitation, or 4 of the ones that were listed among the motoric quiet subtype. So there are different strategies for recognizing it or defining the different subtypes. Never been compared, no good qualitative or quantitative stuff. So it's an early process right now.
Actually, I was referring more to the
Etiology, right?
Yeah,
No.
right, not classification.
Boy, I
It's
just
his
wasted a
hearing.
lot
I
of
think
time.
he's-
No. I learned something. No is the short answer to your question. Nobody that I'm aware of has looked at the cause and effect relationships between hypoactive versus hyperactive delirium in critically ill patients.
Thank you.
But a good question. Yeah.
Good evening. Is there enough information or evidence for the use of, or for restrict the use of benzodiazepines?
With regards to what? You said, is there enough evidence for the use of benzodiazepines?
restrict
For
the use.
restrict the
Oh, for
use of
restricting.
benz.
No. And no. I think it's, the jury is still out. I think if you have a delirious patient who's CAM ICU positive or ICDSC positive, you probably don't want to use benzos in those patients. That's one of the guideline recommendations. But the guidelines do not say that you should never use benzodiazepines. And in fact, and this is another area of controversy, for alcohol withdrawal patients, the recommended drug of choice is still benzodiazepines. And so it's hard to go against the existing published guidelines for that, even though they're very old. Those guidelines were printed in JAMA in 2004. And most of the research on ICU delirium has happened since that last version of the guidelines was published. The other population, of course, is a patient who's on chronic benzos. That would be a very bad idea to stop their benzos cold turkey just because you had an existing ICU protocol that says thou shalt not use benzos. And I have to say, of all the topics that we considered for these guidelines, and as I said earlier, they're very extensive guidelines in terms of their scope and depth of the topics covered, that this subject of benzos and the relationships, the relationship between the use of benzodiazepine and delirium was probably the most contentious issue amongst the 20 people on the guidelines panel. And we spent hours and many email exchanges discussing what we thought we could and could not say based on the evidence. And we were afraid that people might read the guidelines and say, and conclude that they should just stop using benzos altogether in the ICU because it's a bad idea. And that's not what we're recommending. Yes.
Just for Dr. Murray, in the military, are they running straight ketamine infusions or ketamine with benzos, or are they
No, they're straight ketamine infusions.
no benzos?
They're not administered routinely as part of it. They're all getting something during the course. I can't say they haven't gotten any because they're with us for 2 to 4 days. But the only time they would stop, the only time they would use a benzo for certain is when they were discontinuing the ketamine to when you're at the highest risk of developing a hallucinations or something. So then they would, but I suspect most of them have something else on board, an opioid, you name it.
I've got a question, then we'll take another mic question. How do you sedate patients with low blood pressure? Great question. So anticipating that is tough, right? I don't know that I can predict whether dexmedetomidine, propofol, midazolam, lorazepam are going to cause more or less hypotension in my patient. So it's a bit unpredictable. I guess the easy answer is, first off, do you need to be as deeply sedated as you are? Can you lighten up your drug and lighten up your patient? Volume loading is something we always do. We have moved recently for some patients where we may ping pong from dexmedetomidine to midazolam to propofol and have hypotension in all of them. We may go to a primary opiate-based sedative regimen with supplemental lorazepam or something like that and maybe get a little bit less hypotension in that setting. I don't know what my colleagues are doing. So.
I think the other possibility is, besides striving for a less is more strategy, the less drug you have on board, the less hemodynamic side effects you're likely to engender. And also, if somebody's hypotensive, and they're not deeply sedated on sedatives, you have to be thinking about, well, what are the other reasons this patient's hypotensive and so sensitive to low doses of sedatives? And so, you know, whether it's hypovolemic shock, distributive shock, poor myocardial performance, or some combination thereof, you have to look at those things rather than say, well, we can't give him a sedative because he's hypotensive. And you have to assume, even if a patient isn't hypotensive, when you put them on sedatives, particularly in conjunction with opioids, even at low doses, there can be very profound synergistic effect on blood pressure, which is why it's generally a good idea to kind of start low and titrate up rather than get heavy-handed and give somebody a big bolus of something that's more likely to cause hypotension. But I think the other thing I wanted to say is, having said everything we've said about the benzo controversy, is there is good data to show that using more than one sedative at once allows for tremendous synergy, which enables you to get away with much lower doses of either sedative than you would have had to give to achieve the same depth of sedation if you just used one sedative. So that's another tool in your toolbox that you can consider using. I think you have a separate question though, right? Go ahead.
Thank you very much for brilliant presentations. I want to know how far we are from S-ketamine, this, the level rotatory ketamine, as opposed to racemic ketamine, which we are using now. And if it's not too far away, will that be available for clinical uses in the ICU, considering all its, positive effects, being able to combine so many potential benefits in one drug?
No clinical studies yet of which I'm aware, but for the same reason in answer to Dr. Gilbert, I believe that there's a theoretical reason that it would have benefits, but the studies aren't there. And from the guidelines perspective, if there's not information, it can't be based on expert opinion, but sensitive to the issue for a lot of other substances, whether local anesthetics, neuromuscular blockers, racemic mixtures come with a lot of problems associated with their use. And maybe if the military had looked at S-ketamine as opposed to the L compound, they might have found a difference. I don't know.
Interesting.
Okay,
Remember dexmedetomidine is the dextroisomer of medetomidine, which was the veterinary drug, which was the racemic mix. So we're already 15 years down the road with that drug. Well, that's a great question.
I just want to make one last comment. Did you have a question? Were you raising your hand? Yeah, go ahead.
I understand, generally speaking, when you have light sedation, patient has a better clinical outcome.
Can you move the mic down a little bit more? Yeah.
Generally speaking, when you have like lighter sedation, clinically outcome is better. Anybody look at within this light sedation, people use different medication. Some people use like 1 or 2 midazolam every hour. Somebody may use 10 or 20 midazolam every hour. So it's only a difference within this categorical light sedation, but dose, the big, huge difference. Is that dosage make any difference?
Yeah, I've not
For
seen
the
that.
long-term clinical outcome.
Yeah, I've not seen that in ICU literature. I think Dan Sessler had a triple disorder paper a couple of years ago. I don't know if that answered that question, though. It's a low biz, I don't know. Yeah.
It's a really good question, though.
Because in our hospital, we're in the New York, some people use like 1 milligram per hour. You can sedate patient, can say the light sedation, but some people can use 20.
Yeah,
I
there's
don't know
a great deal of
but they still
pharmacodynamic
consider
variability.
light sedation. If you talk with the patient,
Right.
yes. It's like drinking the alcohol is like nothing.
All we know is deep sedation is bad. Whether within the same target range of sedation, more of one drug is also bad than less of the drug. We don't know the answer to that question. It's a good one.
Also, any of you guys try the low dose ketamine with the low dose propofol?
In ICU patients?
Yeah.
Yes, there's one study I can think of, but I don't remember the details of it offhand.
Because do you think it's better just like use propofol or just use ketamine?
No,
I start use like combine those two because I have some colleagues come from the Cleveland. He told me in the Cleveland clinic, everybody use like put ketamine 200 in the 200 propofol. Just say
There's a follow-up review paper that's coming out about sedation and pain management in a separate journal in the next few months. And I just edited this paper, and there was a section in there about the importance of what Dr. Murray's practice is, notwithstanding, the importance of combining the ketamine with another sedative to try to mitigate the risks of psychosis associated with ketamine. And also using relatively low doses of ketamine helps that too. But I can't remember this.
I am not an advocate for using ketamine by itself. I'm just a
No, I was
witness
just
to
talking
what's
about
going
the
on.
ICU. Your
But
ICU
in the military, out in an austere environment, it's ketamine, propofol, fentanyl. They, Craig McFarland has written several articles on this. They use it in combination. But he's an anesthesiologist opposed to some of the trauma surgeons who need more education, apparently.
So the question
sir.
for Dr. Murray. I use ketamine 0.15 milligram per kilogram in ICU for about 6 hours for post-op pain. And with this delirium guidelines, so that protocol is going to disappear, and I will not be using it anymore?
Are you asking if the guidelines are recommending that we not use ketamine? Is that what you?
That's why, because
No.
most of
No.
the guidelines are saying that there will be more delirium, and ketamine is causing all these hallucination and delusions. So
No, that's not what we're saying.
No,
Right.
and again, within our grade methodology, there's no good data that says, I mean, we've all seen those things,
Right.
but there's not studies that say that, so we do not make that statement.
okay, yeah,
Yes,
that's one to make it
absolutely
clear.
not.
I think these guidelines in general, and some people will find this a good thing, and some people will find this frustrating. We really tried hard to dig through all the evidence to find out where there was evidence for drug-specific interventions. In other words, use drug X in this circumstance, use drug Y in that circumstance. And actually, if you do a side-by-side comparison of the old version of these guidelines, it was very recipe-oriented. They made very specific recommendations for drugs that you should use for short versus long-term sedation versus neuro patients. And when we went back and took a second look at the evidence, those statements really weren't backed up by the evidence. So to the extent that there are recommendations at all that are drug-specific, those are generally weak recommendations that were based on evidence that we felt met our standards to evaluate. So for some people, they're going to find that to be kind of freeing. They're going to continue to be able to use whatever their little favorite drug cocktail is in their ICU. For other people, that's going to be very frustrating, I think, because hospitals that are in the process of or have developed pain protocols and sedation protocols that are first and foremost pharmacologically based, they're looking for what drugs to plug into their little decision tree to use under different circumstances. And I think people are going to be expecting our guidelines to help them develop those drug-specific protocols. And I'm here to tell you that's not what they're going to do. What they're going to do is say, here's the evidence. To the extent that we can tell you which drugs are safer in what situations than others, you can take that information and incorporate that into your guidelines. But beyond that, we're not going to tell you whether you should use opioid A over opioid B because they're all equally effective at relieving pain when titrated appropriately. But for some patients, it's a bad idea to use morphine, for instance, as one of the speakers said earlier, in patients with renal failure. So you have to be smart about the clinical pharmacology of the drugs in different patient populations. And I think the other thing that's frustrating is we've gotten a lot of feedback from people both within the guidelines and outside the guidelines about what to do about the neuro patient in the neuro ICU. And that's a really special case. And this sort of gets back to the demented example. So patients with neurotrauma or neurologic catastrophes in a neuro ICU, it's very hard to assess those patients and be sure they're not in pain, be sure they're not delirious, be sure that they don't have a primary anxiety disorder. And a lot of the data that has been published is not specific to that patient population. There is a growing body of data about best management practices for the neuro patients, but it's very new and it's evolving. And we actually have a paper coming out on that topic too in the next few months. But I think that is an area that there really needs to be some fundamental pioneering research on this issue. And for other patient populations, that's perhaps an extreme example. There's similarly not enough evidence that's specific to a specific type of patient population, like a trauma patient population or a cardiac surgery patient population. Very often these studies are large, kind of mixed bag, med-surg, ICU studies, take all comers, but they're not specifically trying to answer these questions for specific patient populations. So I think that will be somewhat unsatisfying to people who think that, well, my patients are special and unique, and I don't really see how these guidelines apply to my patients because I'm looking at the evidence behind these recommendations and they don't include my patient population. Ergo, do I throw them out completely? And I would say the answer is no. The fundamental premises, I think, are universally applicable to all ICU patients. Treat pain first, then sedate, prevent, detect, and manage delirium in that order. So if you remember nothing else from tonight's talk, that's what you should leave with. Not which drug is best for this circumstance or that circumstance because I got my favorites or I got the ones I don't like. I don't think the guidelines are going to answer questions like that in great detail, but it will give people a framework that they can take back to their ICU tomorrow and they can start applying. And it's low tech. It's stuff that's within reach. Door remodeling notwithstanding. So, any other questions? You guys have been wonderful. Thank you for sticking around.